All right, so yeah, today I'm going to talk about pediatric brain tumor updates. A few disclosures. I am an advisory board member for SOBI, Sanofi, and Octapharma. And one most important disclosure, I'm not a neuro-oncologist. I've come to CAGLA a few years in a row now, and usually we talk about leukemia, lymphoma, bone marrow transplant, those things. So I figured CNS tumors, brain tumors need a little love, so we're going to talk about those. All right, so outline for my talk, epidemiology, genetics, we're going to go through those quickly, tumor types by location in pediatric patients, symptoms, some novel treatments and treatments currently in clinical trials, as well as some cases. All right, so the problem is kids get brain tumors, and it can affect any part of the brain. It's the most common solid tumor in children. Low-grade astrocytoma or low-grade glioma is the most common type of brain tumors that we encounter in pediatrics. Approximately 5,000 diagnosed per year in the U.S., so it's a significant burden for these families. Younger kids, definitely over the last 10 to 20 years has been on the rise, so less than 14, kind of a little line in the sand there, older kids, it's been pretty stable. So different treatment types, surgery, radiation, chemotherapy as broad treatment options. High morbidity and mortality, as you can imagine, especially if you've seen these patients. They go through a lot, and it's one of the leading causes of death in pediatric oncology. All right, so this is a little bit older graph, but it kind of drives the point home that in that 0 to 4-year-old segment of children, there are much higher incidence of gliomas, pilocytic astrocytoma, as I mentioned, medulloblastoma. There's a little peak at 5 to 9, and then kind of dwindles as you get older. But we take care of patients in their 20s, 30s with medulloblastoma, and no longer called primitive neuroectodermal tumors like on this slide. The World Health Organization changed that. It's more term based on their molecular features. So, and also in that embryonal tumors like ATRT and also embryonal tumor with multi-layered rosettes. And the only one that really kind of goes up with age is the pituitary tumors. So not many in young children, but we think about craniopharyngiomas being more common in the older teens. All right, so this highlights, so adults, there's a much higher incidence of brain tumors in adults compared to children, but if you noticed in the children, from 0 to 19 years of age, they have a much higher percentage of malignant tumors versus non-malignant or benign tumors than adults do. So, kids often have very aggressive tumors compared to the adults. All right, so pediatric brain tumor distribution, not going to go over all that, but just some highlights. One of the highest is, like I mentioned, the medulloblastoma being 20%, then cerebellar astrocytomas, 20%, other low-grade gliomas, pilocytic astrocytomas making 18%, and then you have your less common ones like your anaplastic astrocytoma, GBMs being about 10%, your brainstem gliomas, which are very horrible to treat, and none of us want to see those, and so forth. Much smaller percentage in the other tumors listed. All right, so etiology. So about 2 to 8% of patients have an underlying genetic predisposition syndrome. That could be neurofibromatosis, could be, as a classic one, tuberous sclerosis. Other TP53, like Li-Fraumeni, can also have some brain tumors. Also ionizing radiation, if they've had radiation for some reason to the CNS prior, then that can predispose you to a brain tumor in the future as an adult. And there's been questions, do cell phones do it cause this? We hope not, right? Because I know my kids are probably both have brain tumor. No, just kidding. But yeah, they're always on their phones. Industrial chemicals, diet, classes like organic chemistry, who knows? But usually it's probably a de novo mutation in most of the patients. All right, so I love anatomy, very basic to where even I can understand from small town Louisiana. This picture here it talks about the tentorium, which is a dural fold that kind of separates. I didn't ask about where the pinpoint is, but it's a fold that kind of goes over the cerebellum and then across and around the brainstem, with most of the brainstem being infratentorium, like on the right picture there. So infratentorial, so cerebellum plus a good part of the brainstem, and then anything supratentorial is your cerebrum, your pineal gland, your ventricles, most of your ventricles except the fourth ventricle. All right, so distribution by age, location, so infants, about 50-50, supratentorial, infratentorial. Then there's a big increase in infratentorial with children, and adults is the opposite, so supratentorial. So like that's where your meningiomas, your GBMs, those type of things are usually in the cerebral hemispheres. All right, tumor types. So go through this. There's a bunch. I'm not going to spend much time on it, but infratentorial, you can have the pilocytic astrocytoma, medulloblastoma being the ones that are more aggressive and malignant. Those are embryonal in nature. Ependymoma can really occur anywhere, infratentorial or supratentorial, but more common infratentorial, like in the third, fourth ventricle. Or brainstem glioma, not good. As I mentioned, ATRT, also very aggressive tumor in younger patients, and it's embryonal. Supratentorial, any type of astrocytoma, your JPAs, SEGAs, which are in the tuberous sclerosis complex, all of these. Anaplastic astrocytoma, so increasing aggressiveness with these WHO classifications, and GBM, which is very aggressive in children and adults. Not PNETs, but what we used to call PNETs, so pineoblastoma and other embryonal tumors with genetic abnormalities. Ependymoma, craniopharyngioma, so that's in your sella turcica there, and affects pituitary stuff, choroid plexus, a small percentage in germ cell tumors. So just to go over some signs and symptoms that we see, so infratentorial, usually you think about more kind of basic functioning like brainstem, increased pressure. It's a smaller area, so nausea, vomiting, headaches, vision disturbance, altered mental status in the younger kids, cerebellar things like your ataxia, cranial nerve findings, and so on. Supratentorial, just kind of more higher functioning things, so like seizures usually occur in the cerebral hemispheres, headaches as well, memory loss, cognitive changes, and so forth. Motor, if you hit the motor sensory strip, personality changes, the frontal lobe involvement, things like that. All right, so the change in handedness is very interesting. I've had several patients with that where they kind of become ambidextrous, but better with the opposite side of the tumor that the tumor affects. So it's pretty cool in young children that they can adapt well. So basic treatment guidelines, so neurosurgery, of course, gross total resection if you can, but a lot of times it's not feasible depending on the location. Radiation, nearly all brain tumors are radiosensitive to some degree in varying levels. Not used up front for your low-grade gliomas or astrocytomas or other benign. I put the benign in parentheses. A lot of the gliomas are not, they may be benign mitotically, they may not be very mitotically active, but they, depending on location, can cause lots of problems as much or more than the malignant phenotypes. Tumor bed, the radiation is usually much higher to the tumor bed, so anywhere from 54 to 59 centigrade for most protocols. Then craniospinal irradiation, not all brain tumors, but the ones that tend to metastasize will get CSI ranging from 18 to 36, so your medulloblastoma is kind of a classic one that can metastasize down the neural axis. And we try to avoid craniospinal irradiation less than 3 years of age, but that's kind of not always possible, but we try to, especially in the younger kids, just with the rapidly developing brain. And then chemotherapy used as adjuvant therapy. Certain tumor types are more sensitive and blood-brain barrier is a big problem in developing new drugs. I'm not going to spend too much time on this this slide, but pediatric high-grade glioma is the ones we really don't like. So your K27, so based on methylation, the two on the left, the K27 and the G34, those are typically very high-grade and poor prognosis. They have these multiple recurrent oncogenic drivers. So what that does, it allows tumor escape mechanisms. So that's why they're so difficult. One reason why they're so difficult to treat is you target one thing, but then it uses these other pathways to kind of escape your therapy. You know, with the K27 methylation profile, they're using more brainstem, very difficult to treat. You know, approximate median survival 6 months. So that's like your diffuse midline gliomas. And then all the way to the right, so the pleomorphic xanthoastrocytoma-like is considered in the high-grade glioma, but much longer, better survival. So survival can be greater than 4 years, like shown there. And it has some BRAF mutations, which I'll talk about a little more further in my presentation. All right, so case one. So a 7-year-old male presenting with 1 month history of headaches, a 1 week history of nausea, vomiting, worsening in the morning, kind of classic brain tumor type stuff over the past few days, off balance, and has been falling. Exam, there's concerns with papilledema, so swelling because of increased intracranial pressure, and just difficulty with tandem gait and finger to nose dysmetria. So this for that type of patient, this is a classic imaging where you see kind of midline cerebellar tumor, not well demarcated. There's some areas, probably the darker black areas, some necrosis, and just kind of varying shades. And then on the sagittal on the right, it actually goes down and into that fourth ventricle. So you can imagine the flow of the CSF leads to the increased intracranial pressure, you know, pressing on the brainstem as well. So not good. This is a patient with medulloblastoma. So as I mentioned, also was previously called cerebellar or PNET. It's the most common malignant brain tumor of childhood. Common age is like 5 to 7, 8 range, about 1.5 cases per million. Nausea, vomiting, headache, ataxia, kind of classic things. Up to 30% can have dissemination along the neural axis, so down the spinal cord is where we look for disease. Typically midline. Picture on the right shows those drop lesions, we call them, down the spinal cord, multiple lesions on the spine in that patient. So there's histologic variants, and that can kind of portend prognosis, as well as molecular subgroups, 4 big ones, which we'll talk about. So the large cell anaplastic, or the more aggressive histologic phenotypes. Skip through this. This is kind of older risk classifications. Big thing that really advances that have led in oncology, pediatric neuro-oncology is molecular profiling. So we know a lot more now about different kind of methylation profiles, but also gene expression and mutations that kind of drive some of these tumors, so leading to targeted therapy. So there's for medulloblastoma, the subgroups can help correlate genomic alterations with clinical outcomes, and also helps reveal potential therapeutic targets, and you can augment or de-intensify therapy based on the subgroup. So this is a cool slide that the 4 big subgroups, so your Wnt, your sonic hedgehog, group 3 and group 4. Prognosis, Wnt is actually very good prognosis as far as medulloblastoma is concerned. Sonic hedgehog is kind of intermediate, as well as group 4, intermediate, but group 3 being poor. That's a lot of that has to do with the MYC expression and other issues with that one. This just shows kind of the varying degree of if you're low risk versus the highest risk based on metastatic disease or MYC amplification and large cell anaplastic. So the worst one being down all the way to about the 20% progression-free survival at early as 2 years and beyond, since that's your worst prognosis one, and that's the ones that have all of those bad prognostic indicators. Whereas the low risk, if you can resect, and the ones that have the WENT pathway can be up to like 90% progression-free survival. All right, so classic therapy, so resection, best resection for both, radiation, like I mentioned before, cisplatin, Cytoxan, vincristine, in some degree of that for most COG trials, and less than 36 months, because we're trying to avoid radiation, they get higher dose chemotherapy plus stem cell transplant and have a fair 50 to 70% overall survival, 5 years. Some challenges, so surgery, difficult, like I mentioned, your small space, there's a lot of important things there. Posterior fossa syndrome, which is pretty scary when you have patients can become mute, and irritability, all of these things. And radiation, of course, growth, ototoxicity, cognition, neuroendocrine, or worries even beyond 3 years of age. Obviously, the brain continues to grow in childhood. Chemotherapy, ototoxicity from cisplatin, and there's other toxicities as well. Some newer therapies, so WENT agonist, it actually works as a tumor suppressor in the sonic hedgehog pathway, and currently there's trials exploring to see if it can be effective in the group 3 and 4. These sonic hedgehog inhibitors that I'm not going to pronounce, there's some clinical data and clinical trials for those. One of the big side effects is premature growth plate fusion, but after stopping the therapy, there can be some regrowth there. And then this CK2 inhibitor is exciting as well. It can work as a sensitizer to temozolomide to allow kind of synergy there with that chemotherapy agent. So case 2, so 8-year-old, similar age, presents with several month history of headaches. Last 2 weeks been sleeping more, headaches have worsened, kind of similar symptoms. Just to highlight, can be similar location, but definitely different treatments and different prognosis. So this one, compared to the other, this is much more well demarcated. You can almost see like a circumferential capsule around this one. Also, this isn't the same tumor, but a lot of times these can have the cystic appearance, nodular and cystic. So this one, it was a cerebellar astrocytoma. This is one of the low-grade gliomas, most common benign brain tumor of childhood. 1/3 are supratentorial, 2/3 infratentorial. Try to get gross total resection. Sometimes that's all you need is gross total resection or near total resection, and then observation versus chemo and radiation if needed. Some newer therapies that are exciting. This is really where molecular testing and has really changed things. Is in the BRAF mutation, BRAF V600 is kind of the classic, but there's also multiple BRAF fusions and that can be targeted. So the BRAF V600 altered low-grade gliomas, so dabrafenib has been around for a little bit, plus vemurafenib. So you can use monotherapy in these tumors, and there's been really good data and COG trials with dabrafenib plus the MEK inhibitor trametinib used in combination and comparing, and also in the next one, the BRAF KIAA duplicated low-grade glioma, so selumetinib, which we know we've used for plexiform neurofibromas in F1, but there's upfront studies in non-NF patients looking at selumetinib plus or minus vinblastine comparing to standard carboplatin and vinblastine, so standard chemo versus targeted, and there's some preliminary data suggesting that there's improved response with that agent. Recurrent progressive low-grade gliomas, we have options now. So tovorafenib is an exciting one. It's a type 2 BRAF inhibitor. It was fast-tracked and is available. It can be used in 6 months and older. And so these recurrent or progressive low-grade gliomas, there's also studies looking at it in high-grade gliomas as well. And yeah, there were very favorable responses in the PNOC trial, which is your Pacific Neuro-Oncology Consortium. Other high-grade glioma therapies, So PARP inhibitors are used, NTRK inhibitors, so like lararectinib. ONC201 is used for some high-grade gliomas and diffuse midline glioma. It's a DRD2 or dopamine receptor antagonist, as well as this protease antagonist, and is used in combo with multiple drugs with some preclinical positive findings. Other targets, so there's so many targets. Also, like I said, one of the reasons why they're difficult to treat, there's so many mechanisms that they can evade the immune system as well as your therapies. But these are some other targets, so PIK3, mTOR, and NTRK, like I mentioned, plus others. H3K27 is bad. It's seen in really high-grade ependymomas, diffuse midline gliomas, used to be called our DIPG, which is one of the most feared brain tumors that we see, other high-grade gliomas as well. Trying to use the Panoba, I don't even know how to say that, something stat, Panovastat, histone, so it's a HDAC inhibitor, limited treatment though, so there's still not a lot for H3K27, right, almost at time, almost done here, but so a lot of exciting things in immunotherapy. So there's immune checkpoint inhibitors that we're trying, so that we've used for other tumor types in pediatric oncology. So your anti-PD-1 and CTLA-4 inhibitors, still under investigation for high-grade gliomas. Adoptive cellular therapy, so CAR-T. We already heard about CAR-T for solid tumors as well as for liquid tumors, but targeting GD2 and B7H3 CAR-T. There's been few cases of response, but not really long-lasting response, unfortunately. But hopefully we can improve those therapies. HER2, so like you hear in breast cancer, there's a CAR-T for recurrent and progressive ependymoma. It's a phase 1. It's early, showing that it's tolerated and there may be some efficacy, and I think it's going to go to phase 2 trial. And then also delivering CAR-T trials directly into the CSF is exciting, that researchers are looking at for like ependymoma and medulla to give localized, to really aggravate and enhance the immune system within the tumor, to try to treat it internally. Cancer vaccines, also looking at that for the diffuse midline gliomas, the H3K27, and also oncolytic viral therapy is very exciting. One of our former colleagues at UAB developed some exciting HSV technology, and that's also being studied in these high-grade tumors, and also other viral agents like measles, polio, and stuff. There's a lot of exciting stuff there. Big things. Another big thing we worry about, I kind of mentioned this, late effects, so neurocognitive, endocrine, secondary malignancies. Proton radiation is typically more favored over traditional conformal radiation therapy, just because you can use higher doses of proton versus photon and cause less off-target toxicities. Just kind of shows that IQ does go down with radiation, especially conformal radiation therapy, even as early as 12 to 24 months after, well, probably earlier than that, but this just kind of shows over time, definitely changes in IQ. So summary, most children with low-grade glioma, cerebral astrocytoma, medulloblastoma, ependymoma, and craniopharyngiomas will be long-term survivors. Future research, treatment modifications to decrease the morbidity of brain tumors are important, and really the infants and patients with anaplastic histology, metastatic disease, ATRT, all these bad things need newer therapies, and we're kind of partially on the way, but there's a long way to go. All right, I went over time as well. So, yeah, I'd like to open it up to questions.